The rib counting. Wow, absolutely. Do you remember exactly which lecture that was in? Chest lecture 1. What slide? 22. And my drawing screen is not working, so we're going to have to work through this together. Yeah, I have to guess where it's at. I don't know why this one is not working. There we go. Alright, enable content. So you want to learn how to count the ribs, correct? Okay. Let's find a good picture on that. Let's do anterior first. Ooh, will it let me go over there now? I won't be able to draw on it, can I? Okay, I can show it. All right. So let's do my best with this. Okay. So anterior ribs first, right? So when I'm looking at anterior ribs, remember the way that the thorax is shaped and the ribs are shaped, they're going to be my more steep ribs because of the wraparound of the axillary portion. The x-ray is done this way. Sorry, I'm turning my back on you, but the x-ray is done this way, posterior to anterior. So my posterior ribs are more horizontal, but then it wraps around. It's a game of shadows. And then on top of that, the anterior ribs come around and come up towards that sternum, right? So you end up having this steep kind of shape on these anterior ribs. So when you're counting the anterior ribs, you start off with number 1, right? And you just look for that steep shape. These ones are easier to count if you know the right shape and you're picking the right rib, okay? So just look for this steep incline on the first one. Really, if you look right here on the spine and in the center here towards the top, and you just start shifting laterally and find your first rib that has that steep decline, that's going to be rib number 1. And then you count down from there, 2, 3, 4, 5, 6, 7. Right? We can do it right here. We've got them right here on this side without the highlights. All right. Now if I go posterior, I can't click because I don't have it in the computer. But let me go back up to the posterior one, like this X-ray here. Okay. If you go posterior, posteriors are more horizontal, right? I know they're coming down a little bit, but they're much more horizontal than this steep decline. So look at my anterior ribs. Look at how steep they come down. Number 1 here, number 2 here, number 3 here. 1, 2, 3. Those are the anterior ribs, okay? When counting the posterior ribs, they are the more horizontal ones. They're more prominent and they're more horizontal. How do I count those? Look at 1 and 2. 1 and 2 are going to overlap, and it's going to be different based off of each patient. 1 and 2 are very difficult sometimes to pull out. They might be sitting right on top of one another. So if you don't realize that, you can easily start miscounting by not seeing that 1 and 2 are that overlapped. So what I do is I start with my anterior rib, even though I know I'm counting posterior, because they're connected. It's all one rib, right? It's just a matter of the location of the thorax that they're in, posterior or anterior. So I start with number 1 and go, okay, so I trace it up. 1 goes in there. I know this is 2 anterior, I follow it up, it goes in there, and once I follow up 2, I know my next one down horizontally is 3, and I count down from there. I'll show it over here. So I find my first anterior, follow it up, so that's posterior 1. I found my second anterior, because that's easy to see. 1 and 2 anterior is easier to see. You rotate it up, and once I follow 2 all the way up, once I get here, then I start counting 3, 4, 5, 6 down posteriorly, because 2 and 3 will always have that separation. 3 doesn't overlap like that. Does that help? Okay? So it's a little tricky in the aspect of where if I'm asking you to look for posterior ribs, if you're trying to count them, the trick is find the anterior first, work your way back so you know where 1 and 2 are, and then work your way down posteriorly. So that way you don't accidentally miscount. And then in order to do that, you need to know that the posterior ones are the more horizontal ones, and the anterior ones have that steep decline. Steep decline kind of in the background of the image. Okay? That answer your question? Yes, ma'am. Rec 7, slide 51, coming right up. Ignore my desktop. There's a lot of things. But I just mean, it gives some people anxiety to have like all the files sitting on the desktop and not in like neat little folders. For me, it works better for me that way. I have an ADD, ADHD brain. I like it all over the place. When it's on my computer, it's organized much neater, but I only have one screen here. Okay, so acute pancreatitis. What do I need you to know from here, right? The biggest thing from the pancreatitis, how does that patient present? What are your symptoms? What are you ordering for imaging? Okay? Pulling out a pancreatitis on a CT just by itself without suspecting that it's going to be pancreatitis, I'm not going to give you, just this image. We'll use the acute one up here. This is unreasonable for me to give you just this picture and say, what's the diagnosis? Right? Unreasonable at your stage to give you just this picture and say, what's that diagnosis? But if I gave you the picture with a vignette that describes a patient we have concern for pancreatitis, then you use the vignette to go, hey, I got these abdominal issues that we've talked about in this course. There's plenty more abdominal diagnoses we haven't talked about, right? But I have these abdominal issues that we talked about in this course. This fits these things. That's kind of on my differential. Now I look at the image and, right, do I know that's the pancreas? Maybe not, right, 100%. But if I know my anatomy and I go liver, spleen, oh, epigastric. Okay, that's the epigastric region. I was kind of convinced based off of the vignette already that I was thinking about pancreatitis. And now I have all this inflammation and fat stranding that we talked about on the image in that region too. All the image really does is help confirm the fact that you were suspecting pancreatitis from the vignette. But I can't give you just this picture and say, what's wrong with the patient? You're not there yet. Eventually in clinic, when you start getting there, you may be able to pull this out, right? But not right now. I need to give you a vignette. Does that answer your concern for the most part? Excellent. Ma'am. On x-ray, I would have to, right? Unless it's a large bowel, because we didn't really talk about large bowel ileus, right? But for small bowel, yeah, I gotta give you something, right? Because they look very similar. They both have dilated bowel. They both have multiple loops. They both are gonna kind of present the same from image. But then there were very specific things that make you go, do I think this is ileus? Do I think this is obstruction? One was your physical exam findings, right? The other one was your patient history. Not just the most common, so surgical type stuff and when that surgery was, but also the review of systems, right? What are their bowel movements like? Are they still passing gas? Are they not? When's the last time they had a bowel movement or gas passing? So there are clues within there that help you go, this picture definitely, I see dilated bowel, I know it's one of these things, I know something's going on. From the picture, is it small or large bowel? That's something you should be able to pull from the picture. But then if we go small bowel for sure, ileus or obstruction, give me some information. Yep. Yeah. Good. What else? Ma'am.
Will you be able to kind of like, because I have a hard time trying to distinguish the atelectasis and the silhouette sign. They all look very similar to me, especially when it's on the lower lobe.
So silhouette sign is a sign, so I want to be clear. So an atelectasis can cause a silhouette sign. A silhouette sign is not a condition, it's a finding, is what I'm looking for. All a silhouette sign is telling you that there's an issue in a particular lobe. That could be a pneumonia, that could be an atelectasis, that could be multiple things. So you have to use the other things that you know about atelectasis to figure out that silhouette sign is due to an atelectasis, or is it due to a pneumonia, or is it due to a consolidation, or is it due to something else? Does it have that triangular shape that we kind of talked about, pointing towards the central structures? Is there any type of pulling of the mediastinal stuff or not? Are the symptoms fitting of atelectasis versus a pneumonia, right? So just understand that silhouette sign is just telling you that there's an abnormality in a potential lobe area, but that does not tell you silhouette sign versus atelectasis. An atelectasis can cause a silhouette sign. A pneumonia can cause a silhouette sign. A cancer, a mass, can cause a silhouette sign. A silhouette sign is just one of those things that make you go, there's something wrong here. It's in this lobe most likely if I don't have a lateral, right? Now, what else can I use from either reading the image or using the patient history and vignette to figure out what is the cause of that? So it's not one or the other, because atelectasis can cause silhouette signs. What was yours?
Sir, I guess in my notes I kind of missed it, but you said something about for the aortic aneurysm that would look similar to something else, and that you would only provide one of those answers since they look relatively the same on X-ray. What was that?
Ooh.
And then we said,
Are we talking aneurysm versus dissection potentially?
Was it that?
Because I know aneurysm and dissection on X-ray are going to look exactly the same. The difference on that one is, are they having that tearing, ripping back pain, right? Because that's that layer of the aorta being pulled away. So, and they're kind of in the same slides together, right? Aneurysm and dissection are going to look the exact same on X-ray. You would need to do a CT with contrast to fully evaluate that vessel to figure out if it's just an aneurysm or if it is a dissection. But that patient's symptom of that tearing back pain is what leads you towards being more concerned about dissection than aneurysm. I think that might be what you're talking about. There are many things that can cause an aortic aneurysm, right? An aortic aneurysm, it's like one of those things to where when you have congestive heart failure, well, what caused it? What was the comorbidity, right? Aortic aneurysms don't just happen, right? There's something else that's causing it. Maybe it's long-standing hypertension, which we looked at, and that had an uncoiling of the aorta, right? The hypertensive cardiovascular disease. So what I'm getting at, I guess, what might be answering that question is read what I'm asking you to find, because you're gonna see an enlarged aorta on X-ray on a lot of different conditions, right? But what am I asking you for? If I give you a hypertensive cardiovascular disease patient in the vignette, and I'm asking you to tell me what the disease process is or what the condition is, and it has an enlarged aorta, I can't put aortic aneurysm and hypertensive cardiovascular disease as both answer choices, because technically they would both be correct if there's an aortic aneurysm on the imaging. That's kind of what I was getting at. That's why I say, like, read the question first, because you're probably going to have more than one abnormality on some of these chest X-rays. It's so hard to find just a singular one because some of these patients are sick, right? So understand what I'm looking for from a time management. Did that answer the question? Kind of, sort of. I wish I knew exactly like what thing you had written down or like what it was, but I think it was dissection. And then in general, kind of what I was saying when we talk about testing purposes, if it's on the X-ray, I can't make it a choice, right? Unless I'm very clear in what I'm asking you. And for example, a silhouette sign, not a diagnosis, right? Atelectasis is a diagnosis. So that kind of thing.
Sir, for the review slides on 118, it's down towards the pubic symphysis. So
Oh yeah, that one.
I tried to scroll through and find it. What's like the?
Let me make sure before I just speak off the cuff here. Let me, do I even have the review slides? It's not parabronchial cuffing. I don't even have it in my thing. I think with that particular one on slide 118, for those that have the review, if anybody has it in PowerPoint form, let me know. I want to look at the notes on it. You do?
Yeah.
Does it say it? Is it the prostate removal?
Seeds within a prostate.
Yeah, it's a prostate, yeah. So radiotherapy seeds within a prostate. So yeah, what that is, that's what I thought that was. It's like little radiation pellets they put in there for prostate cancer. That's what that is on slide 118. It's kind of those little radio-opaque areas. So it's a prostate cancer treatment. I can't remember if it was just the cancer treatment or they actually took out the prostate. Those were surgical clips. So those are like little radioactive.
Just the radioactive implant.
Yeah, just little implants to help take care of prostate cancer. Yeah. Yeah. I'll pull this one back up. All right. What else? Daniels.
Sir, what is the cardiophrenic?
Claustrophrenic angles?
No, not cardiophrenic,
Where are you seeing that? What's
right,
what slide and deck and all that stuff?
deck one, slide 1700.
This guy?
Yeah, the green dashboard is to the left.
Oh, the cardiophrenic angle? Oh, this is just where the right atrium ends up going into the lung areas, right? So these are costophrenic angles because it's the ribs and the lungs kind of coming together. This is just the right atrium can sometimes form that kind of little angle in there. Nothing we really discussed in detail and length, so I wouldn't worry about it too much as far as the test goes on Tuesday.
And the follow-up is looking at the airways,
Mm-hmm.
how do you distinguish what is a middle lobe, a right middle lobe versus a right middle lobe?
On this one?
Not on this one, but just from this day.
Yeah.
specifically.
So there's two ways to do it, right? Either if you just have the frontal or the PA or the AP view, right? You just have that. First of all, there needs to be an abnormality, okay? That's the first thing I'm gonna tell you. To try to kind of pick this out, right? On a normal one, it can be very difficult. But if you have the silhouette sign, that is the first thing, okay? Middle or lower, depending on if it's hiding the cardiovascular area, or sorry, the right atrium of the heart, or if it's hiding the hemidiaphragm. I'm trying to find that area that we talked about. Or if you're trying to distinguish it with a PA and a lateral chest X-ray, then what you need is these guys. It's like that 75. It's understanding the area that we're at. So you have to use your PA and your lateral in combination to take a look and figure out what area are we talking about. Because on that PA, there's my right middle, there's my right lower. Look at how the right middle lobe on the PA and the right lower lobe overlap. There is no way for me to tell with just the PA on a clean x-ray, right, which if this area is right middle or right lower. I have no idea. Okay? No idea. I need the lateral to figure out if it's in this area, right lower, or if it's over the heart in this area for right middle to be able to figure that out. Unless I have, go back to a normal x-ray, unless I have a silhouette sign hiding the right border of the heart or the right hemidiaphragm. Because that we talked about, if I have the silhouette sign hiding the right border of the heart or the right hemidiaphragm, I am likely thinking that that is going to be right middle or right lower lobe based off of where that silhouette sign is at. But without that, I need both pictures, and you just have to know where these lobes are so you have an idea of kind of is it middle or lower. Okay? Does that answer your question? Yeah. Sir?
You said a lateral chest X-ray is always going to be a left lateral.
Always left lateral. Always.
It shouldn't matter which side the spine is on. It's always going to be left lateral.
It's always left lateral. Always 100% of the time. There is never any reason ever, very rarely do I use this as I've said, right? I don't use always and never in medicine. There is not any reason for you ever to see a right lateral chest x-ray. Right lateral decubitus, yes, sometimes, depending on where the fluid's at in the pleural effusion, right? But a legit lateral chest x-ray, it will never be right lateral because if the patient is able to do a lateral chest x-ray and they're not bedridden, then why wouldn't you do it left? Left is always the answer because it keeps the heart closer to the film, decreases the magnification of the heart, and it's a better overall image. So there will never be a right lateral x-ray. Yes?
Hey, sorry, going back a couple questions with the aneurysm.
Aneurysm, yeah.
I think what he was talking about was hypertensive cardiovascular disease.
Uh-huh.
They essentially present the same,
Uh-huh.
and that uncoiling
Uh-huh.
of the aorta
Mhm.
looks like an aneurysm.
It probably is.
So, yeah, so I'm assuming that if it's something like that, then both wouldn't be an answer. Right?
I said that, man. I got you. Yeah, no, correct. They can't be, right? They can't be. They can't both be an answer on that. Unless I specifically have an arrow pointing to an abnormality, asking you to tell me what is that what is that? If I'm pointing to the enlarged aorta, I'm asking you to tell me why is this there, right? But I'm not gonna have both of the same thing.
What if you have dextrocardia?
Explain dextrocardia.
Just a little flip-flopping going on.
Yeah, so the official term, the disease process for that, we kind of talked about at the beginning, is sinus inversus as well, right? Where everything is flip-flopped. Yeah, what if you have it? You're still gonna get a left lateral chest x-ray because that's the standard, because the x-ray tech's not gonna know you have dextrocardia. So it's still gonna be a left lateral, always, right? Always left lateral, that is the standard, and I am not giving you any patients with dextrocardia or sinus inversus because the percentage of those patients is extremely minuscule, and there's always been one that has. That's okay. You're good. That's a good question. What else? Where are we at? All right, I saw somebody else stand up. Ma'am. Deck 2, slide 22. Okay, what was your question now? Okay, cephalization, right? A review on cephalization. So before I explain cephalization, let's explain the normal anatomy, right? The lung markings, the vasculature, right? Same, those are the words we're looking at. Those are the branch-like grayish lines, right? Radial opaque lines that we're seeing throughout the lung fields, okay? Now, because of that, the lower third is more full or easier to get lots of fluid and blood than the upper third. Why?
Gravity.
Why? Gravity, right? Gravity is a lot easier if I have to go down, which means my vasculature up top in a normal chest x-ray is going to be less prominent. So those lung fields are going to be more radiolucent, a little bit darker, have less prominent vasculature, and not have very much compared to the lower third, right? When I have cephalization, it's fluid backup. I'm having so much fluid backup throughout my congestive heart failure or whatever is causing cephalization that is now making my vasculature in the upper third much more prominent than my normal chest x-ray, right? So the first step is looking at it and going, well, I know it's supposed to be darker up there, but boy, that doesn't look right. I have a lot of vasculature. Step 2 to confirm that is compare your vasculature and densities from the lower third to the upper third. If the upper third is not more radiolucent or darker or have less vasculature than the lower third, that is cephalization. Because it should get darker as it goes up because the body pushes blood up there. The vessels are smaller up there anyways because there's less lung tissue. It pushes it up and the blood just falls right back down, right? It doesn't just sit down here like it does lower because of the gravity. So that's what cephalization is backup of that fluid causing the lung markings or the pulmonary vasculature to appear more prominent on a chest x-ray than it normally would. Does that answer your question? Perfect. What else? This is good stuff. Bam.
It's just more like a confirmational question. So some of the slide you mentioned, study of choice is CT with contrast.
Uh-huh.
Some of them just say CT.
Right,
So when
and-
you just say CT, that means CT with
So, I said a couple of times through our lectures, and I have no problem confirming that again. In this block, right, unless I specifically tell you CT without contrast, it's with contrast. Because all your vasculature needs contrast. All of your organs are gonna need contrast. There were very few things that we talked about in this block, kidney stones being one of them, kidney or urinal stones, that are without contrast. So when you go through the slides, unless it says without contrast in it, you can consider it with contrast for this block. And because almost everything is like CT is study of choice and with contrast, I don't even know how many of those I have on there. Still getting previewed by Major Mechanical. So if you don't like my test, you blame him, not me. Because he makes sure it's good for you guys. Have you guys had him? Has he started teaching psych yet? No?
Is that him anymore?
Huh?
He's got the lane now.
Oh, that's right, Captain Lane does psych now. He does med history now. That's for the freshmen. I forgot that moved to Captain Lane. All right, what else? What else? Sir? Thank
Some
you.
of your slides put the left lateral, sometimes the spine's on the left, sometimes the spine's on the right.
Still left lateral. Still left lateral. Ideally, they should all end up being flipped. Let me find it. Yeah, Cardi B. Left laterals. Right? So ideally, and this is a perfect example, they should all kind of be flipped the other way, but it doesn't really matter. It's still a left lateral. That's why I wanted to make that clear. Because it just depends on how they send it over, but either way, it's a left lateral. And again, don't get so hung up on it because regardless whether, the only difference between a left and a right lateral chest x-ray, guys, the only reason it's left lateral is to decrease the magnification of the heart, right? That's the only reason. There are no anatomy changes, there is no view changes outside of the fact that the heart might be magnified on that if we do a right lateral instead of a left lateral, because these lungs are superimposed on one another. So you're not gonna see anything different regardless of this way versus this way, except for the fact that the heart might be more magnified. So don't get so hung up on the left and right for the chest. It does not make a difference. It will always be left regardless of which way that picture is flipped. Okay? Sir?
Sir, would you be able to kind of help me differentiate between segmental and interstitial pneumonia? It's kind of like the main takeaways. It's going to say it's segmental. Like both of them look fluffy to me, and I can't really pick out exactly
Which,
where it is.
where was pneumonia?
I'm looking at just on your review slides, and it's slide 44, but I can't remember exactly which.
It's deck
Deck 3?
Deck 3, yep, that's what I'm going now. Airspace disease, interstitial lung disease. That's it. Thank you. Okay. So, segmental versus interstitial, right?
Yeah.
Okay, so segmental, take a look, we've talked about kind of like the segmental, it's in the different segments of the lung. Here's my normal, right? Kind of can see the branching out. What I want you to focus on between the segmental and the lobar, so I'll get to your interstitial, right? But segmental and lobar, or lobular, look at my lobular, look how it's just sitting in a lobe, right? It's in the majority of one lobe. I can almost map out that that's probably where the right middle lobe is. I have my silhouette sign a little bit, but if I have my lateral, I'll be able to pull that out. But notice how it's not affected per se in some of the other areas. I can see my hemidiaphragm, so I have my lobar pneumonia, right? Now I shift to segmental, that's not as well mapped out, right? It's not quite the whole lobe, it's in different segments, it's fluffy, right? So, got that one. Now if I go from segmental to interstitial, the difference with the interstitial one is not necessarily the fluffiness, right? Look at the graininess of the chest x-ray. This one more looks like somebody threw sand on it and took the x-ray. And look at where it's at. It's all over. Can I have both in my segmental? Sure, I can. But I got this one and it's like a bunch of dots. It looks like a bunch of grains of sand. So yes, it's still fluffy, doesn't have the distinguished borders that the lobar necessarily does. But it's fluffy in a different way. And on top of that, I have a very specific patient subset that gets infected typically with interstitial pneumonia, right? So that's gonna be another clue to kind of help you distinguish between the two. But imaging alone, go off of the graininess, the diffuseness. It's kind of like a bunch of pieces of sand versus I got that segmental kind of pneumonia in like the different airways in that area. Does that answer the question?
Yes, sir.
Okay.
Just a follow-up on
Yeah.
that one. Does it have anything to do with kind of the outline of the heart kind of showing more almost like not like a pneumopericardium, but like
As far as this x-ray goes, the segmental, not necessarily.
that's not going to be like the key thing.
Correct,
To look at it. It's
correct.
just-
Yeah, no, good question, right? Right? And then the biggest one between this one, right, and we talked about some of these alveolar ones, is that air bronchogram as well, right? This is how I know this is segmental or interstitial as opposed to alveolar. I don't have those air bronchograms, right? I can't see that radiolucid tree branch. So that's what tells me that we haven't quite gone to alveolar edema, or this is more of an interstitial or segmental type thing. Sorry, segmental, I use interstitial wrong, but that grainy sand is your interstitial, those immunocompromised patients. Yeah. Yes, sir?
66, example of lobular pneumonia.
Yeah.
Is there, can you put up the air bronchogram if there is one there?
There, let's see. I don't know if I have one on this one. I don't. There isn't one. There's just a silhouette sign on this one. But it would not be abnormal to see an air bronchogram because it's the entire lobe, right? And so that's kind of what I was getting at. But this image does not have an air bronchogram. So if you couldn't find it, good job. Because it's not there.
Sir, deck 4, slide 21, the pneumothorax with like the ultrasound. Walking through kind of what we're looking at with the seashore sign.
Seashore. Oh, you're looking for a little girl named Sally. Who's Sally then? By the seashore. Probably for too much. Okay, so EFAST, pneumothorax, right? Ultrasound. So let's start off with the normal. The normal is going to be the seashore sign. See, you just want to say it. Why is that normal? Because what the ultrasound has done is first, as we saw before, you have found the area between two ribs and you've put that line. Like, hey, this is where I want you to evaluate. I know I'm between the two ribs, evaluate here. You switch to M mode to that motion, and it takes a picture. So what the idea is now is the ultrasound is taking a continuous picture of that area, okay? So when the visceral and parietal pleura are sliding upon each other, when they're breathing, and there's no pneumothorax because they're touching and they're sliding like they're supposed to, the ultrasound doesn't know how to read that. So you get that choppy area in the bottom because at different times, it's in different areas. So it's not reading it that well and it's getting different feedback. So that's where you get your beach side, okay? Sandy beach. Then you get a little bit of hyperechoic area in the ocean waves, and then afterwards, because this is going to be like the start of the lung tissue, and then afterwards, this is like deeper, right? You don't have to worry, it's just the sky side, no motion tenderness because it's not seeing anything, it's gone past the pleura, because it's only evaluating, this is the only part that's moving, then we get that very little motion and then no motion because we're past the pleura, right? So that's normal. A good day at the beach, everybody likes to be at the beach, that's normal, we want to see that. When I have a pneumothorax and I have air in between my pleura, my visceral and parietal layers, right, moving, what is ultrasound's enemy? Ultrasound's enemy is air. Sound waves don't get through air well on ultrasound. So even though the layers are moving, there's air in between them, so the ultrasound can't see it. It can't see that parietal pleural layer. So what's happening is you get barcode sign because it just sees the one pleural layer and there's no motion. And so that's what's positive. Positive is the barcode sign because there's no motion to the lung and the two pleurals sliding against one another. Does that answer it? Okay. I saw a couple hands as you went that up. Everybody good on that? Okay. What else? Ma'am.
Sir, is it reasonable to find out where the hilum is by counting the ribs?
Not necessarily. No, I mean, you can get a generalized area, but there's no specific rule to where like the hilum is always in between posterior ribs 5 and 6 or 6 and 7. That is not a thing. So you can have an idea of where the hilum are supposed to be, but it's not like if it's not in between these ribs or by these ribs that it's abnormal. So, no. Yeah. What else? What else? These are good questions, guys. And they're like deeper level questions, right? So not surface level. So it makes me feel good that you guys are going to be solid on Tuesday, especially after the weekend study. Yeah, what's up? Deck 3, slide 18. Let me get there first. Because then you ask the question, and I'm like, what did you ask again? Because I'm old. Slide 18. Oh, you got to ask about this one. What's up?
So, speaking on the interstitial disease specifically.
Sure.
Between reticular and nodular, it's pretty evident with reticular and reticulonodular. It's very similar in both sarcoidosis,
Mhm.
essentially.
Mhm.
So I just want to know if there's a key difference between the two that is something to pay attention to if we're looking at X-ray.
One has nodules, one doesn't. But that's, I mean, honestly, don't get hung up for Tuesday. Okay? Don't get hung up distinguishing between, so reticular and nodular, sure. But as far as trying to pull out a reticular nodular compared to one of these two, if I were you, I wouldn't spend a whole lot of time trying to figure out and pull out, is this reticular nodular or is it just reticular? Is this reticular nodular or is this just nodular? Does that make sense? I don't often give a whole lot of hints on the exam, but yeah, don't spend a lot of brain power over there. This is more hey, you're gonna see this in clinic, certain things, not everything falls into bucket A or bucket B. Things can fall into bucket C, right? Focus on bucket A and B.
radial, lucid, circular, those are the nodules?
No, the nodules are radiopaque. The nodules are radiopaque. Nodules are the areas that are not supposed to be there. The best way to look at this slide is to pull this slide up next to a normal chest x-ray. That's the best way to look at this one. And then you'll really see the differences in which ones. It's all radiopaque. So if you look down here, right, my nodulars are, again, it's all sarcoidosis stuff, but it's also can be metastatic disease in the lungs as well. So these can be metastases as well. So it's the radiopaque areas. Because a normal chest x-ray, this should be fairly radiolucid except for my lung markings, my linear vasculature, that is those tree branches that are more radiopaque. There are no radiopaque nodules or circular areas really in this in the lungs, especially down in the lower third. Yeah. Okay.
Sir, question for the ultrasound and like placement of the ultrasounds. It says indication. What makes it a positive exam? Are you looking for like the posterior sign versus?
Nope, so the slide with the locations of where to do the ultrasound, that is just to show you where you would do the ultrasound for all those areas of the EFAS.
Oh, okay.
The indications for the positive exam is the pictures that I showed you that show the fluid where it's not supposed to be. Has nothing to do with the locations of where the ultrasound probe is on that one slide.
Okay, so it won't be like right anterior chest and you're looking for a pneumothorax?
No, I'm gonna, if I give you anything with EFAS, it's gonna be the pictures that we talked about. It's not gonna be a locational type thing. I'm gonna save that for senior semester. When you guys go to eMed, you actually get a section of EFAS and do it on each other. That's where you'll be tested on that kind of stuff. That's just to show you kind of where we put it, to help you kind of put in your mind, you're like, well, he says left upper quadrant, so how do I know, like, I'm seeing, like spleen and kidney? Why? Well, because look at where we're putting it, look at how it's pointing. It's just to kind of help you understand the process of it.
Okay.
But you guys, for this radiology course, imaging course, focus on normal versus abnormal when it comes to the EFAS pictures, not necessarily probe location.
Thank you, sir.
Yeah. What else? So I've said it over and over again, right? Said it about block 1, block 2 compared to block 1. Know how patients present. Know the whole picture. Know the whole concept. We're not just interpreting images. Some of them, yes, you will, but some of them you're using the images as adjunct to confirm what you should be thinking after you read the question, the answers, you read the vignette. Okay, I'm thinking these things. Now let me look at it, right? So there will be some straight up anatomy questions, right? Offer a couple of softballs to help kind of boost that up a little bit. There'll be one or two, probably third order, kind of more complex ones, probably typically one, right? You're gonna have some second orders. In other words, here's the symptoms, here's the patient demographics, here's an x-ray. What's wrong? Or without an x-ray, here's the symptoms, here's the patient demographics. What are you gonna do next? What are you ordering? What's either the study of choice, or what are you, sometimes not even study of choice, just what are you supposed to order to further evaluate that, right? So, it's more than just, you have to know how to look at the images, you have to know how to interpret the images, but it's more than just that in this block. People who usually do pretty well understand the full patient symptoms, because then even if they're lacking in the x-ray read, if they're not 100% sure, based off of the vignette, they're like, oh, my educated guess is this. And usually they can get kind of close on something like that, even without the x-ray. What other questions? Oh, thank you. Are you talking about all the masses in the mediastinum? The anterior, middle, posterior?
More just kind of how to really, more really how to kind of discern what's really there. So I was scrolling through radio TV last night, and I found one that was like, there was a carcinoma.
Mm-hmm.
And the note on it said that it was just easily distinguished as an anterior mass on PA because of the increased capacity of the aorta.
You need a lateral for our course, right? right? Easily, so here's the catch with Radiopedia, here's the difficult part with that. When they write those things, they are being written by people who have years of clinical expertise and years of experience and doing some of this stuff. And they go, oh, it's a cancer. I promise you, the only way they knew that is because other stuff happened after the x-ray to confirm that,
Right.
right? And so when they're like, oh, it was used, yeah, because you had more information than what we covered here, right? You did a biopsy and they told you you had cancer, and then afterwards you go, oh yeah, obviously it was an anterior mass, it's right. No, you're not looking at a PA x-ray, and I would not want you to, and nor should you, look at just a PA and look at a mass or something like that and be like, that's anterior mediastinum, for sure. Because without a lateral and some other information, you don't know for sure. Now, you can get all that info, and then 6 months later, after doing the full case study, like what's in Radiopedia, come back and go, oh, yeah, why didn't, obviously, it's right there, right? So I wouldn't get so hung up on that. I want you to have both, because I showed you where those compartments were on the lateral chest x-ray, right? Intentionally. Yeah. Good stuff. What else? Anything else? How we feeling?
Awesome.
Right, yeah.
Right now.
Let's take it tomorrow.
How are we feeling knowing that there's still 3 days, really 3.5 days, because we got that virtual day on Monday, to kind of get through the material some more, okay? I will be, it's virtual day, right? So on Monday, I'll be on Canvas watching stuff for like emails and stuff like that. If you have any questions, try to be as specific as you can in the question, because I'm not looking at what you're looking at. So it's kind of hard for me to be like, when you're like, hey, on this picture, and I don't have the picture. So if you could put it in words and kind of like, distinguish between a disease process or another one, like an atelectasis versus a pneumo when it comes to the mediastinal shift or something like that, it'll be a lot easier for me to kind of answer you back. But I know it's a virtual day, you guys will be in class kind of watching all that. I will also be on my computer. So if, as you're studying stuff, I can tell you that I will be answering questions on Monday and checking my Canvas regularly throughout the day, probably up until about 1900, because that's when I start doing my dinner and bedtime with the kids and all that other kind of stuff. So if you send it to me after 1900, I may or may not get to the response. But anything sent to me Monday before 1900, I will get you a response before I turn it in for the night on Monday night. So feel free to send me some questions in Canvas if there's that burning thing of hey, and it's possible, depending on how deep the question is, with you being less than 12 hours from the exam, I may just respond with, I appreciate where you're at, move on to other stuff, we can talk about it after the test, right? That doesn't mean send me a slew of questions trying to get what's on the test, right? I'm only going to do that for extremely deep kind of stuff. For example, this reticular nodular thing, like I just did in here, hey guys, focus on reticular and nodular, don't worry about the in-between. It'll be that kind of stuff. It's not gonna be oh hey, don't worry about atelectasis. No, we're not gonna do that, right? But because of the uniqueness of the weekend and then that Monday virtual day, I'll be available online on Canvas if you need anything. Other questions? Okay. I have a feeling don't depart just yet. Yep, stay in your seats. Dad's here. But if you need anything, let me know. I'll still be around today, probably until about 1500. I do have a meeting at 12. But if you want to swing by my office, if you have any burning questions, I'll be around till at least 1500 today, doing admin stuff, possibly a little bit later, so feel free to come by. Good luck. You guys are going to do great. All right, thanks for your time. You guys have been great. Appreciate your class.
Thanks, sir.
Sir, can you explain the difference between Rolando and Bennett?
Take too much of your time with